Good evening. I'm Dr. Mitchell Sokoloff, professor and chair of urology at the University of Massachusetts Medical School and UMass Memorial Health. It's a pleasure to welcome you to tonight's Health Leadership Brain Trust webinar entitled Walking the Walk, Embracing a Culture of Diversity and Health Leadership. A brief description of who we are. The Health Leadership Brain Trust is a prominent healthcare-oriented MBA brain trust which furthers mastery and implementation of healthcare leadership in the science of medicine and management. As physician leaders, our mission is to improve healthcare for everyone, to lead the national conversation on healthcare change, and to empower other physicians to do the same. Tonight's webinar is designed to be an interactive discussion on the current state of diversity and inclusion in healthcare leadership. Awareness and championing of diversity and inclusion in healthcare is not a new concept, but has become a hot button issue, especially this past year or two. Institutions are concentrated on how to establish and maintain a diverse workforce, as well as addressing the social determinants of health and overcoming the health disparities that impact our patients. For tonight, we've assembled a talented group of physician leaders. We have representation from academic, community-based, and military medical institutions, as well as from the biomedical injury. I'd like to introduce them to you at this time. Dr. John Gould is professor of surgery and chief of the Division of Minimally Invasive and GI Surgery at the Medical College of Wisconsin, where he also serves as the vice chair for quality. Dr. Lisa Davis is a gynecologist obstetrician with ProMedica Health System in Ohio, and she is also an assistant professor at the University of Toledo College of Medicine. She has extensive experience as a military physician, having served on active duty in the United States Navy and presently serving in the Air National Guard as a flight surgeon. Dr. Jason Friedman recently transitioned from a distinguished career in neurology at Sibley Memorial Hospital, which is part of Johns Hopkins Medicine, and now works for Novartis Pharmaceuticals in neuroscience, clinical development, and medical affairs. Dr. Irina Dubinchek is a pathologist who has worked at several health systems in Massachusetts and is currently on the medical staff of Mount Auburn Hospital and is a consultant medical director for Tufts University Health Services. I want to welcome all of them and thank them for participating. We have left time for questions. If you would like to raise a question, please use the chat function to send those questions to us, and we will make sure that they are answered. So at this point, we should get going, and we're going to start with our moderated discussion. The first question is going to be open to all of our panelists, perhaps starting with Dr. Gould, and it's a question with two parts. What is the current state of diversity and inclusion within leadership of healthcare institution like yours? And what are some initiatives that you or your organization have implemented to help with this? So we'll open up with Dr. Gould to start.
Thanks, Mitch, and thanks for allowing me to be a part of this panel. I'll speak for the Medical College of Wisconsin. Obviously, we have room to improve in this area, like all places across the country. Diversity, equity, and inclusion has been a priority in our department, in the medical school, and with our hospital partners for a long time. But obviously, with the landscape over the last couple of years, it's taken on an increased sort of priority and pressure to improve and to critically examine what we're doing. I know best what we're doing in our department, and there's similar activities happening across the enterprise. So within the Department of Surgery, there's been a number of different things that we've done. Our residency program is more than 50% female. Our faculty is predominantly male and predominantly white, but that is changing. We've had a very deliberate process about hiring. We've formalized the process for recruitment, formalized the process for convening search committees to make sure that it's got diverse representation. And we've sort of created some structure and format to the interview process that allows us and has enabled us to do structured interviews and some other techniques that will allow us hopefully to hire with diversity in mind. We've created a diversity, equity, and inclusion committee in the department. We have modeled after the University of Michigan a cultural complications conference. So it's in place of our M&M every other month. And there's actually a curriculum that you can get from the University of Michigan. And we've taken some of our own local examples and champions where we talk about different sort of scenarios and vignettes where issues of diversity and equity and inclusion are brought to the forefront, and the language and the science and the data is shared widely. And there's a lot of other things that we're doing, but it's part of our everyday conversation as we strive to learn more and to do better. And clearly there's opportunity there.
Thank you. Dr. Davis, the same question. What's the current state of diversity inclusion at your institution, and what are some initiatives that you or your organization have implemented?
So I come from a unique perspective in that currently I have 3 different jobs and work for 3 different organizations. One is as an OBGYN with a health system in Northern Ohio, the other as a flight surgeon with the Air National Guard, so the military, and then the third with a health system in Southern Ohio, where I primarily focus on working with residents. Like John has mentioned, I think at the forefront now, because of things in the world, we're seeing more of a push to either strengthen the diversity, equity, inclusion at all the institutions I'm affiliated with, or even creating positions and creating departments that focus on that. With the program where I deal with the residents, it's been interesting to see that primarily there have been female residents, and currently out of the program, there are only 2 men. And often we hear about diversity in the other way, where it's not enough women, not enough minorities, but in this instance, not very few men. So our recent match, we actually matched 3 males into the incoming class, which was unheard of because that program has been dominated by females for the last 10 years, I would say. From the military standpoint, it is a work in progress. And I think that recently with the events that happened at our nation's capital, it has opened the eyes of the leadership on that end for them to look more at what we can do to expand and improve how they address things from that end. And my last job, or the main job with ProMedica, they have really expanded their efforts to become more diversified. That health system includes several facilities that are in rural locations, so that always poses a challenge. But importantly, what I'm seeing is that the efforts and the conversations are being had across the board. So.
Right. It's interesting. At our own institution, they matched 1 male in the gynecology program. They're very happy because I don't think they felt they're going to match any men. Moving on to Irina, you've been at some academic and clinical programs too. And what do you view the current state of diversity inclusion and what your institutions have been doing?
Yeah, at Beth Israel Lahey Health System, there is a commitment to diversity, equity, and inclusion. But I would like to speak about Tufts Health Services, where I'm a consultant director of a laboratory. In this organization, and I'm proud to attest how this organization is focuses not only on the law required regulation policies, but also embraces every opportunity to learn about unconscious biases within and outside ourselves, and also tries to include diversity within the staff, but also within serving multicultural student population. They established the processes that ensure the culture of inclusion, and everyone is open to discuss the organizational structure and how to improve it to make sure that the process of inclusion involves everyone.
Thank you. And last for this group, Dr. Friedman, You have the recent experience at the Hopkins Health and also obviously with Novartis. Your thoughts?
Sure. So, and actually, I'm gonna try and touch on my experience with my medical school, which is Georgetown, recent Hopkins, and then Novartis. Although I do not speak for Novartis, I'm just giving my opinions. And starting there in my more recent position, what I would say is that D&I has really become a part of strategy, and so it's no longer a separate office. It's no longer a separate function, but it's literally strategy that has been cascaded down from the highest sort of parts of the organization right on down to the everyday worker. And one of the ways in which they've gone about doing that is empowering that everyday worker to be a part and form committees that themselves are going to decide what sort of initiatives and things they undertake to improve on the diversity and inclusion within their own division. And I think that it's been really refreshing to actually see that in action, because you see, in many cases, majority folks beginning the conversation about D&I initiatives and things that they want to do to change the current standing of the organization. So I'm sort of really excited to be a part of that. And it's really refreshing to see, because I think what you see most times is it's led by an office. It's led by a specific person. And because of that, it doesn't necessarily permeate the organization in a way that makes it truly strategy. They, in the last couple of years, have moved to actually formalizing the process. So whereas I would say 4 or 5 years ago, there was no US director, they now have a director. He's actually actively building his team at the same time as, again, they're cascading these goals and initiatives to the rest of the organization. So that sort of speaks to where I think the business side is. From an academic institution, if I go back to my days at Hopkins, they hired an internal candidate, made that person the head of D&I for all of JHHS. And what's really nice is they are very, very active. So not only cascading down, but they send out a weekly newsletter to talk about new positions, new opportunities, and the things that are going on an everyday sort of basis, so that people are really actively aware of what's happening. And again, sort of making it a part of the conversation and a part of the ongoing strategy. Finally, at my alma mater, Georgetown, the new dean of the medical school is an African-American male, which is, a night and day transition, something that people probably thought would never happen at that particular institution. But I give them kudos to saying, we're going to have top-down leadership. We're going to put somebody in place who's different, who looks different, who may speak differently, and who can lead in a different manner. And so that's my perspective on the current state of diversity and inclusion.
I have a quick follow-up question that none of you are expecting, I just thought of, but a quick yes or no. Jason, Irina, you're in East Coast, Mid-Atlantic, large cities. Jason, Lisa, you're in Midwest and smaller cities. Do you think the location of your institution helps or hinders recruitment and retainment of a diverse population, whether it's residents or faculty? Jason, you're nodding your head. I'll start with you real quick. It could be a yes or no. Real quick, real brief answer.
I'm in DC, so yes, it helps.
It helps. John?
I think I don't think it helps. Milwaukee's a diverse city, and parts of it, the suburbs aren't. Wisconsin is not a very diverse state. Yeah. And so I think it's an impediment to a certain degree.
Lisa?
I think with where I work most of the time, it's a hindrance because Toledo is the closest big city, but it's not that big. Cleveland is close in the other direction, but when we're talking diversifying the 10 hospitals within the health system and the offices, it's a hard sell. There are cornfields and cows outside the door. And people want to sometimes go to places where they have people that look like them to have that kind of built-in network. So when you're trying to recruit or fill positions, you don't have that in this situation. And so even if you recruit members and physicians and midwives and all, they don't stay. So they might come for a few years and then they're gone and the organization's right back where they started. So I think it's a hindrance in that situation.
Thanks. And to keep on time, let's move on to the next question. Irina, this is Dr. Dubinchek. This will be for you to start with. What do you see as the major benefits of embracing diversity within the leadership of a healthcare institution? And you're on mute. There you go.
I'm part of immigrant communities, so it's a little easier for me to see from the side of improving patient provider communication if you have a cultural diversity and racial diversity in a provider pool. There is also increased innovation when you have providers with diverse backgrounds and diverse cultural experience. And hopefully the diverse,
there was always the set of twins of two little boys.
Diverse group of.
Yeah, they big now.
Can you please mute yourself if you're on?
They ain't grown, no. Oh, they still there. Mm-hmm. They big boys now. Sometimes you see them out there playing basketball.
Who is that? If you're not one of the panelists, please mute yourself. I'm sorry, Irina, go for it.
That's all right.
Oh, okay.
The diversity also helps to improve.
I was coming home today and Maurice's boys growing up. He was out
awareness
there
and emphasis on health disparities.
He was just waving at me. I said, "Oh, look how friendly he is! Much friendlier than his daddy."
Excuse me, A. Johnson, can you please mute yourself?
Oh my God.
Yeah. All right, Irina, please.
All right. So we're trying to have a patient as a center of a multidisciplinary team. And if multidisciplinary provider team also is multicultural, diverse, then it helps to provide the best quality of care. So I think that's one of the benefits of a diverse environment where everyone can feel welcomed and included.
And as you said, coming from an immigrant background yourself, that's obviously very meaningful to you, which is a great perspective. Lisa, how about yourself? What do you think the major benefits of embracing diversity within healthcare leadership?
So for any Star Trek fans out there, I liken this to we're not the Borg. So our country is a diverse country and founded on that diversity. And so to that end, we need to see in our healthcare leadership that diversity. The patients we care for come from diverse backgrounds. And so the benefit to having a diverse leadership is that I think we can better relate and, like Irina said, provide better care, higher quality care to our patient base when we have that diversity and we're not just all the same. That is my feeling on that.
I would agree with you. Actually, a follow-up, Lisa, just we have a question that kind of relates to the first two questions, but you're probably the best person to answer it. What would the panel suggest for recruitment in southern or rural areas like where you work in, from everything from nurses on up? Are there strategies one can do to help recruit a diverse workforce in, for example, rural Ohio?
I got recruited to my current position because I did locums there. So that is one way to maybe think outside the box, but you still maybe have the same issue that you have to encourage people to consider these small town options. But a lot of locums assignments end up being in smaller areas because that's where the need is. But once I think people get to the assignment, if they're doing locums and kind of see the people, see what it's like, it gives it a better or presents a better opportunity for them to be willing to stay like I did. and to sign a contract and continue on. So that is one option of thinking outside the box. Another option is to maybe not look at traditional work models. So that classic, 8 to 5 in the office, for the surgical specialties, a day of surgery and call and those things, but sometimes it requires maybe thinking more outside the box. My institution decided to split the workload between myself and another physician because they knew neither one of us wanted to actually live in the small rural town. But by thinking outside the box, we split the month, and for half the month, I go up and work, and while I'm there, I am there. But then the other half of the month, my counterpart goes and works. And so we've been doing that for 4 years now. And it's worked for that situation. So that's another potential way to recruit people.
And if I could just interject to answer the question, for example, even a city like Worcester, Mass, which people don't realize, has one of the largest expatriate African communities. 22% of the minorities within Worcester are from Africa, first generation. Long history of Puerto Rican and Latino immigrants and populations. And I know the medical school, more than anything, really does try to broadcast that during the recruitment, that there really is a history available. Moving on.
So if I could just speak to that.
Please.
I think it's about trying to, what you're saying is there's a community there, right? And so I think sometimes we look at these as a one-off, we're trying to get this physician or we're trying to get this nurse. And I think as a part of thinking outside of the box is how do we build a community that makes one comfortable with being there? And if you can figure out ways to do that, you're much more likely to retain folks over time.
Very nicely put. Thank you for that. Moving on to our next question, more for those who are actively involved in medical education. We'll start with John. If you could discuss progress or lack of progress you've seen in diversity in the medical school and training programs. You already commented that you have a high percentage of female residents in general surgery, which is unique. But what have you seen in the last 5-10 years or even more recently as progress?
Sure. That has been a trend. Our entire chief resident class is female, and it's females are distributed throughout the class. And so obviously I think one of the things that happens is, to Jason's comment, you create a community, obviously, to have women that are thriving at a program. You have to have a program that's sensitive to the differences that they may encounter and all that other stuff. And when there's females there, I think, and they're happy, you're more likely to attract females. And that goes for any other sort of classification, I believe. I've mentioned a couple of the things that we've done in our department that have helped us to increase our knowledge as it relates to diversity. We recently, I mentioned that we're doing structured interviews for the faculty, but we've taken it even a step further for the residency. We contracted with a company called SurgeWise, and they've taught us how to do structured interviews. And we have a very rigorous process, and the candidates are all asked the same questions, and we're all trained. And so it's a reliable way to do the interview that sort of takes some of the implicit bias and the fact that you might relate to someone who's like you, more than someone who has sort of a different background and rate them higher. Just that sort of natural human tendency to do that. And so that's been helpful. We've only been doing that for a year or two now, so we'll see what that does for us. We've really tried to empower the residents in regards to sort of what it is that we're doing as a department and as an organization. So we've embedded them in hospital committees. We've given them leadership positions and a voice. And so we're interested in hearing their perspective. And I think that that's sort of helped the culture of the residency and has helped to improve a lot of different things. So There's a lot of different complementary efforts. I think we're doing a lot better now deliberately because we talk about it all the time and we think about it.
Thank you. Lisa, you obviously teach at Toledo College of Medicine. Same question for you in terms of what changes you've seen in diversity in medical school or residency training.
I'll clarify. So I'm a clinical assistant professor, and I deal with the med students almost as an AHEC rotation. So they come out to us, but I'm not actually at the medical school.
Okay.
What I will say from my own personal experience as a resident, when I started my residency program, I was the only Black resident in the program. And when I arrived at the location, I had several of the support staff, not the physicians, not the other residents, come up to me. And at my institution, the majority of the support staff were Black, but they came up to me at different intervals and said, you know, they don't like Black people here, they're racist. And the last Black resident they had, they ran that person out of here, and that was like 6 years ago. And now you're here. And so imagine what I felt like on day 3 of my intern year, finding this information out. And so it was an interesting dynamic my first 6-7 months, I would say, until I finally talked to one of my 3rd-year residents, and they kind of provided more background to what had happened. Fast forward, though, so I was the only. And then the year behind me, we had 2 Black residents. The year after that, 2 more Black residents. The year after that, 2 Hispanic residents. And so I'm not saying that I opened the door by any means, but I think it totally shifted and changed. And the institution, and we know the match is an algorithm, but I think we got more diversity in our pool of candidates after I started there, and then it carried forward. So I would say that definitely was a positive thing and a push in the right direction in that situation. The medical students that I've been working with through the Toledo Medical School, it has been somewhat diverse, but as I look through this last 8 months or so, it's still been more male medical students that have come through, my office, but not all of them are pegged to do this particular rotation. So I would not criticize the med school by any means for that. It just is how the rotations, panned out.
And getting back to that theme that you and Jason mentioned about community, once medical students or residents see that there is that community present, it helps recruit more people. For example, I have in my urology department of 10, I've got 7 female faculty. The number of medical students at UMass who go into urology are predominantly women, because they obviously see these as wonderful role models, and you build that and it takes a life of its own. Arena, you also obviously are at Tufts. What do you see as progress or lack of progress in medical school residency diversity?
I actually want to speak to pathology in general. In pathology, Black residents are underrepresented, but Johns Hopkins had an outreach program, and what they did, they outreach to historically Black colleges, and they invited medical students for rotation to rotate through Johns Hopkins, and gave them personalized mentoring. And then the number of rotations increased from 1 in 2013 to 18 to 2019. Quite a few of them became pathology residents. So as Lisa said, having an example and personalized outreach program helps to recruit a Black resident and diversify the pool of residents at Johns Hopkins, and I'm sure it could be done in any other program.
And I've seen some institutions where they start with some of the inner city high schools, getting people interested in science and bringing them in the hospital for summer volunteer jobs and sort of build the interest there. We'll move on to the next question for sake of time. This is going to go to Jason and Lisa. You guys took the heavy load early on. What do you feel are the greatest challenges for healthcare institutions to embrace that culture of diversity? I don't think we've quite covered that topic directly. So Jason, we'll start with you. If you're not muted, unmute yourself, Jason.
I'm sorry, you said what are the greatest challenges?
Yeah, the greatest challenges for a healthcare institution to embrace diversity in a culture of diversity.
Well, maybe I changed that last part to embrace a culture of diversity when there's a lack of diversity.
Okay.
And I think that's probably one of the biggest challenges is that in many places, although, you know, I think it's good that we can all talk about where we are now, some of these changes haven't been put into place. The old guard, I'll call it, remains there. And oftentimes it's not until you begin to see that change in leadership that you can actually see these things begin to take hold and again, sort of see the cascade down from, okay, there's someone else or there's more than one person. There's 3 people now in leadership, man, woman, gay, lesbian, et cetera, who can offer different perspectives that now we go out and there's a different head of HR. And now that there's a different head of HR, we hire in a different way. As John said, we have a structured interview that gets rid of some of the biases. And once you get rid of some of the biases, again, it just sort of takes hold and it seeds the growth. But to me, that biggest challenge is the process of changing the leadership, the process of changing the decision makers is really, really slow. And that just makes it a challenge to hold on to people. And I think what you see is turnover, you see burnout, and you see people leaving the field.
Great. Lisa, same question.
Jason hit the nail on the head. I'll speak from this realm on the military side of things. And I think probably everyone has heard of the Good Old Boys Network, and it does exist in 2021. So that is a huge challenge when we look at military medicine because of the duality of it. It's medicine, but then there's a rank structure that is inherent to the military as well. And so when it comes time for promotions and to be in leadership positions, the good old boys are looking at themselves and who their buddy is. And that is a hindrance, definitely. At my guard unit, it's a guard unit. And this is something that you see in the reserves and guard units that people tend to stay long-term. The main leadership at the higher level for the Air Force, it's the wing level, that changes every 3 years. And it's done that way strategically by design. But at the lower levels, at the squadrons and the group levels, it's this stagnation. And so you, like Jason mentioned, you're sitting and waiting for the old boys to leave so that you can introduce and infuse some new blood in that mix. But if you can't wait long enough, then your people leave and they go on somewhere else. And so you never hit that button, that reset button that is needed. And as we look at diversity in my unit, I'm a flight doc. When I got to this unit, there were 6 of us. 1 doc retired, but I'm still the only female flight doc in my unit. The unit I was at before I moved to Ohio, I was the only female flight doc there. At my prior unit, I was the one of the higher ranking females, and that's not saying a lot. It was a small base, but one of the higher ranking females and the highest ranking Black female out of a very small pool on that base. So if I get out of the military tomorrow, now the people beneath me coming through the ranks don't have someone to look to say this can be done and this can be accomplished. And so I find that as a big challenge, even with where we're seeing diversity at the higher levels with the 4-star generals and people that have been appointed. When I look at that picture, I'm happy to see people of color, but then what I see missing is there isn't someone still that looks like me at that level right now. Or if they have been there, they were there a while back and now they're retired and so we wait. So that is a big hindrance.
It's interesting. About 4 or 5 months ago, Harvard Business Review there was an article on how the military is changing. It might be at the higher officer echelon, but how the approach and the process of promotion of rank, and how they're really trying to take out as much bias and much of that old boys network, as we've talked about, out of it. It's a really interesting paper. I looked at it as a way of just how do you promote people from within a department, but it's pretty fascinating. It was a very egalitarian way of doing things, so maybe that'll catch on.
And I'll quickly mention that part of the change that they instituted is when promotion boards come up, and not too long ago, I was asked to head a promotion board, but they're required. So they're supposed to have a minority, have a female, and hit certain bullets. But if your pool to choose from is only 2 or 3 people, then it's always those same 2 or 3 that are asked to sit on these boards. And yes, on one hand, it's good, but on the other hand, it's not so good that we still have to solicit these same 2 people or same 3 people. And in my case, I can check 2 boxes because I'm female and Black. So you're not diversifying really your board, if I just hit 2 of your boxes,
Understandable. Well, following up on that, the next question actually was similar to that. We'll start with Irina. You just heard a little bit from Lisa, but what specific steps do you see that can be taken to improve diversity within your healthcare institution?
We talked about underrepresented in medicine, the population in medical profession. We talk about us, but I would like to take a different approach and talk about the population that underserved and experience healthcare disparity. And it's a population who are LGBT or people with gender non-conforming or born with differences in sex development. And in pathology, this population, the way we have challenges is with medical electronic system, but also in general, how to establish reference ranges for the results of this population, where the reference range for different tests is not established. The number of transgender individuals is increasing, and a lot of them are young and undergo gender affirming surgeries or treatment. And so they blood work or tissue that we received in anatomic pathology is different from just regular specimens that we receive every day. So being mindful about those differences and how to approach specimens, let's say orchiectomy or breast reduction specimen, mastectomies from these individuals, and how we report it, especially now when our pathology reports that used to be read only by clinicians now are being read by patients themselves. We have to be mindful about the contents of the report. And about the reference ranges, also there are recommendations, and clinicians have to work together with endocrinology, with pathologists, laboratorians to come up with the reference ranges that will be appropriate for transgender male, transgender female, and how they compare to cis male and female population. So the challenges are with that and with electronic health system, which doesn't allow sometimes to perform cancer screening in patients that are transgender, and the insurance company will not pay for some of those tests because they are performed outside of the regular guidelines, let's say pap smear in transgender male.
So that's a very insightful response. Moving on to Jason and John. Obviously now this is a hot button topic, diversity. It's gotten a lot of traction. I know our own institution has so many different levels. We each have a diversity champion within the department. different committees, different administrators. How do we sustain this? I think some of it, as we've talked about, will be self-fulfilling as more institutions have more diverse workforce and leadership, that more diversity will happen. But other than that, how do we sustain these? John, I'll start with you.
I think we need to continue to focus and prioritize this, even as we do better. And I think the pace of change will vary across the country and across institutions. But this isn't the sort of thing where you reach the finish line and you sort of stop paying attention to it because you fix the problem. I mean, this is going to be something that is important, and it always has been, but I think we understand it more moving forward. I think you need to set goals, use data, and set specific goals where you can, and have a strategy to define those goals and to allow you to achieve those goals that is created by a diverse group of stakeholders. And so I think it's just gonna, this is an ongoing initiative, and it's so important for us to work in the kind of place that we all want to work in, and for our patients to have an opportunity to achieve the health outcomes we all desire. So it just needs to be part of the conversation at all times.
Jason?
Yeah, great answer, John. What I would say is, avoid the big flashy rollout. And so, sometimes I think that in response to social goings-on or pressures from, maybe legal reasons, people make a big splash or they make a big hire, and then things go quiet. And I think, especially in the community, and when you're a healthcare institution and you want to improve the health of the community, people see that and they know that as soon as that big flashy thing is gone, your institution or your company is going to move away onto the next issue. And so, I always tell people, avoid the big flashy rollout. Really begin to think about how this, to John's point, how is this a part of your long-term strategy? How do you incentivize people to do this, not just once, but make it a part of their yearly objective? You got to put your money where your mouth is. And so you have to not only build a D&I, division or hire certain personnel, but you have to empower them, and you have to allow them to go out and make decisions and spend money to put people into the right places. And then finally, again, empower the workforce as a whole to change the culture, empower them to make the decisions, to begin to diversify who they work with and how they work, such that, again, it takes hold as part of culture.
Wonderful answer from both of you guys. Thank you. So last question, which we'll divide among the four of us. COVID-19 has clearly highlighted a lot of health inequities throughout our society. How do we begin to address these? In a brief sort of summary statement, since you're right there, Jason, you can start, since you're right here on my screen right in front of me.
Oh, okay. One, I think trust remains a big issue. I think you can go down the line of who might fall into that D&I bucket, but I think amongst each one of those groups, there's a level of mistrust. And so I think whether it be company or, again, healthcare institution, we have to go out and really begin talking to people and building trust. Again, provide resource when there is no pandemic. And so part of the issue with health inequities in COVID-19 is that there are often a lack of resources or lack of resource when there isn't a significant time of need. So the lower income, poor communities, immigrant communities, they need resources all the time. And we have to pay attention to that. And again, make that a part of what we do on a more regular fashion. And does that come down to providing things like universal coverage, increasing minimum wage? Those are some social issues, I think, that need to be thought about and tackled as well.
Lisa, your thoughts on COVID-19 and how do we address this disparities?
Why do I always have to go after Jason? He sums it up so well. It left nothing for me to say.
Because you're next to each other on the screen, so you're right there.
I agree 1,000% with what he said. And before he started saying it, I was thinking that trust is such an important part of the process. And I think what we've seen with COVID and even with the willingness of some groups to accept the vaccine and accept what the potential fallout is if you don't get vaccinated and those things. So I can't phrase it any better than he did. That I think that is very important, and it certainly has highlighted the lack of resources that some communities are faced with. So, and I see that working in a rural setting, that even down to transportation, not just with COVID, but like Jason was alluding to, that just the day-to-day issues that people deal with in the rural town where I'm working, and not necessarily having a car, and there's no bus transportation because there is no bus infrastructure there. And if they need higher level care, we're sending them to Toledo, which is an hour away. And so that by design, by default, isn't going to work, and they're going to, show up in the ER and be sick. So I think COVID really has highlighted that.
Beautiful. Irina, thoughts? There you go.
Yeah. COVID highlighted the health disparity, but I think now what helps is to have the government that has it on its agenda to end racial inequality. And we will strive for equity, not equality, for equity. We will address the patients in need. Also, I would like to say that during COVID-19, it was interesting in regard to education, at least in pathology, but also COVID-related information was coming out in different, from different sources. And virtual platform was very helpful to learn about COVID, but also keep learning for pathology residents, for medical students from different backgrounds, different countries, and bringing everyone together to solve the issues that were related to COVID-19, which at the time was an unknown entity. And it was everybody's experience that was put together by different organizations, and we were learning from each other. So I think that we can continue from COVID-19 experience. The only other thing I would like to add, when we will judge the progress in diversity, we need some metrics, not just to say that we reached that and we reached that, but we need actual metrics that would be the same for different institutions, and we can judge how we progress against some standards or some high quality leaders in the field of medicine.
Very, very true and insightful. John, you want to take us home on this last question on the COVID-19?
Sure. Great summary so far. I mean, I think that, as others have said, the fact that there are differences that there's inequities in outcomes for more and less advantaged populations, it's not a new problem. It's not something that we're newly aware of. COVID really just sort of shone a pretty bright light on that. And so I hope that what we've understood, but haven't really made a ton of progress on, just get some renewed focus and energy. And that's a commitment to examining these health inequities and understanding the fact that they're multifactorial in causation. Trust has been mentioned already, but I mean, it goes even further than that. It's healthcare access and how it's utilized. It's the physical environment, socioeconomic factors, health behaviors. There's just a ton of things that go into this. And, it's flipping back to the MBA curriculum. And we learned a lot about how other countries sort of spend their money on healthcare and things that ultimately result in better health for their populations. And our country doesn't spend nearly as much as other countries do on some of the social determinants of health and other things that I think we really need to sort of critically examine. So I hope that this helps us to move this forward in a way that's been really slow to make progress prior to this epidemic or pandemic, I should say.
So there are a couple of questions I want to bring up. The first related more to the education side of things, and it was, how do we encourage the use of strategies similar to the structured interviews across the country? And I know that we did things very similar to John. Although John, your what you described was pretty remarkable. But I think, the AAMC, ACGME, I mean, if it's institutionalized across the nation that this is the expectation, I would imagine that that's how you get the same strategies used. But for any of the panelists who work in academia, your thoughts?
I think once you learn more about it, how your own sort of personal experiences and perspectives and your interview style impacts, how you rate someone that you interview, and you look at the science and you understand how inexact of a science the current process is, how flawed the way we rank residents and historically have ranked residents is. You really, it drives you to want to change and to do better. I was not aware of this until we engaged these consultants, at least to the level that I am now. So I think it's a increasing awareness. And like you said, perhaps that requires an organization like the AAMC to disseminate this more widely, or to perhaps encourage or create some structure or make this easier, because it wasn't easy for us. It was expensive. Training each individual person in the department to do these interviews took several hours, and it was a lot of resources. So to be trained, you had to commit to do multiple interview days. And so it's a big investment, but I think if this is something that could be rolled out on a larger scale and become more of the standard than it is now.
That's great. Time for one last question. This actually comes from one of this group's co-founders, Dr. Johnson, and she writes in, how do we address implicit bias at the organizational leadership level and all the way downstream? And how do we address this? And she can obviously come on in if she wants to discuss it herself, but if any of the panelists want to give Shanita an answer, please unmute yourselves. And how do we address implicit bias at the organizational leadership and downstream? Silence.
I mean, the only thing I can say is you got to educate. I'm the director of a post-baccalaureate program at Georgetown, and we did an implicit bias training a week ago. I've been on this admissions committee for 7 years, and I think this is the first time we've done it in a formal fashion. The program is geared towards minorities, so there are a number of minority physicians, et cetera. But I think we all sort of found it eye-opening to understand what our own biases were, and how that plays into how we review applications. And so I think the only thing I can say is you've got to continue to educate at all levels that it is something that not only exists, but it can be problematic even when we don't really think about it. Even in, you're not in the majority, you're in the minority, and you don't think you're biased. It's still there. It still affects you. It still impacts your decision making. And so I think it's all about education.
Wonderful.
Any other?
Sorry, Rena, please.
Not only, as Jason said, education is important to recognize what are our biases, or what is microaggression, and we learn how to recognize it. But we also need to have a culture where we feel brave to speak up every time we see the act of microaggression, and if it's against any race. Recently, we saw increase of violence against Asian community. I think at every level, as Jason said, we have to increase awareness of those biases and microaggression and being able to address it every time we see it, not being afraid to say something.
Which is
See something, say something.
Which is difficult, but you're right. You have to challenge people right then and there.
But if the organization helps and creates a culture where it's easy to do, I think it would be done.
So I'm going to give the last panelists time to answer if you want to. If not, I'd like to thank all of the panelists for joining us tonight and for their wonderful insight. And I want to thank the audience for joining us. In addition, we need to give a shout out to 3 physicians from the Health Leadership Brain Trust who work behind the scenes, do a really masterful job on the technical aspects. Doctors Rachel Kramer, Stacy Watt, and Linnea Yang. And you guys do an incredible job of making this smooth. So thanks much. With that, we'll sign off for tonight. Please follow us. We're on Twitter. We're on LinkedIn. Fairly soon, we'll have an actual webpage, and that we hope you will want to join us for future programs. And I want to thank everyone, and I'll sign off from there and leave it to the back end group and Stacy to manage how we do that.
Thanks, everyone. Wonderful discussion.
Great job.
Yeah.
Everyone.
Thank you.
Great job, guys.
Excellent
Thank you.
panel. Excellent panel. Excellent.
Yeah.
Wonderful. Stacy, are we off?
She hasn't popped on yet.
Thank you, everyone. This was great.
Thanks, Simon.
Thank you.
Just waiting for Stacy to turn us off on YouTube.
Yeah.
I think that's it.
Coming off in a minute.
Okay. Did I hear that?
Yeah.
Okay, I think we're good.
Beautiful. Thanks, Stacy.
That was good.
You
Except
hear me?
okay?
yeah,
It still says live.
We
on
can.
YouTube.
it still says live. It still says live on YouTube though. Just make double sure of that. Oh, wait.
Yeah.
It still says live. It still says live on YouTube though. Just make double sure of that.
Can't do anything about it. It's out of my control. Uh-oh. There we go. Go on. Will this end?
Where's Stacy?
Still streaming, Linnea says.